It is September 8th, 2016. My name is Marc Kaufman, and I'm here to interview Dr. Jere Mitchell for the Living History Project of the American Physiological Society. Dr. Mitchell, can you tell us a little bit about your family upbringing and how you became interested in science?
Well, I grew up in Longview, Texas, which is about 120 miles east of here. And there were no doctors in my family, and in fact, nobody had finished college in my immediate family. My family were involved both in the oil business and in the cotton business in East Texas. And East Texas was one of the largest oil fields in the world. So I grew up there, and really wasn't very interested in science to begin with. I was more interested in becoming a doctor. There were two general practitioners in Longview. There was no hospital, and so one of these doctors, Dr. McPherson, delivered me at home, and then he later on saved my life when I had pneumonia. And then another doctor, Dr. Farah, was a good friend of my mother and father. So I saw a lot of these two doctors, and really decided I wanted to be a doctor by the time I was in high school. But I had no idea. I always thought that I wanted to be a doctor back in Longview, Texas.
Can you tell us a little bit about your academic training, both in high school or?
Yeah, in high school I had two teachers that I remember distinctly. One taught me physics, and he was a very good teacher, and the other was the biology teacher. So I began to become some interested in science, but because of those two teachers. But still, my main goal was to become a doctor in Longview, Texas. That was the extent of what I wanted to do. And then after finishing high school in Longview, I went to Virginia Military Institute. My mother liked uniforms, and she thought I would look good in one, I guess. But I think, and I enjoyed my 4 years. Well, I can't say I enjoyed my 4 years at VMI. The first year was constant hazing, and but we did have the 26 people in our pre-med group out of a class of about 250. We started out with 300, but we lost them very quickly due to the hazing there. And Dr. Carroll was really a very wonderful teacher. He had one arm, and when he was giving a lecture and made a point, he would he chewed tobacco, and he would act like he was spitting up his empty sleeve. But he taught us a lot, and was very good about getting people into medical school. When it came to going to medical school, I looked at some schools in Virginia, but I also wanted to come back to Texas, and looked at Baylor University, which had then moved to Houston, and the new UT Southwestern Medical School, which was here in Dallas. Houston had big, beautiful buildings, looked great. I came to Southwestern, they were in shacks, and why I exactly chose this school over that one, I'm not sure, but I'm very, very glad today that I did. The first 2 years in medical school, we did the usual things, but I got very interested in physiology, and then when just before I became a junior student, Dr. Selden came down from Yale University and as a member of the Department of Medicine, but then he rapidly rose to become the head of medicine and almost the only member of the Department of Medicine. And he was very much of a Pied Piper. We all thought he was really very wonderful, and he gave tremendous lectures. And so I decided my sophomore year that when I became a junior, I would take out 3 months during the spring and teach in the physiology department, and then come back and do medicine in the summer. And Dr. Selden told me that was a crazy thing to do, that all I wanted to do was put on a white coat and teach the students and look like a big shot. And what I should do is to come work with him in that summer. But I told him I'd already committed myself, and then I helped him recruit some students to come work in his lab during the summer. But I got to know Dr. Selden better during my junior year, listening to his lectures, and I found out that medicine really is based on science. And I'd really thought about just taking care of people and not really what the underlying field was that made medicine what it is, and he convinced us all that it was science. So I got interested in science. Actually, during my rotation at Parkland that summer, actually did my first research project with a Dr. Al Shapiro, who was very interested in psychosomatic medicine, and we did a study on a few patients who had abnormal T waves due to anxiety. So my first paper was done while I was still in medical school, and then I finished medical school and decided to stay here in Dallas and do my internal medicine training at Parkland Hospital. And there were 8 of us who were Dr. Selden's first group of straight medicine interns. And he had sunshine rounds with us every morning. And at that time you worked every other night, all day and every other night. And every morning we'd have this session with Dr. Selden. And he really convinced me further the importance of science in medicine. And then during that same junior year, a Dr. Carlton Chapman was recruited to come to Dallas from University of Minnesota to be the first head of cardiology. And I met Dr. Selden, and I met Dr. Chapman, and began to work with him some on the side when I did the cardiology portion of my internal medicine.
While you were a medical student, you had a paper published, and can you tell us a little bit about your research as an internal medicine resident?
Well, in internal medicine, we'd either be on the ward or on a specialty service, and I was on the hematology service working with a Dr. Ernest Muirhead, and we decided to do some studies with people with anemia and look at the iron transport system. And so I did a paper with Dr. Muirhead, and we wrote it up, and I was supposed to present it. I was going to present it at the Central Society meeting in Chicago, and I never had given a paper at a meeting. And so Dr. Muirhead told me it wouldn't be any problem. I could read it, and we would have good data, and I'd give the 10-minute talk. And if I had any questions, he would handle the questions if they were very, very hard. And he said, "Oh, by the way, there'll be a Dr. Carl Moore in the audience. He's from Washington University, and he's the giant in this field. He's Mr. Hematology. And I'm sure if he gets up, he'll just get up to compliment you." So I go to Chicago, and I give my talk, and just as I'm finishing, I see this white-haired man running toward the podium, and he sort of said, he actually came to the podium. He asked from the audience, he said, "I've listened to this paper, I read the abstract, I think it's very interesting work, and it was so interesting, I have done a couple of studies to see if I find the same thing. May I show 2 slides? And he goes to the podium and shows 2 slides which are exactly the opposite of mine. So I looked down, I didn't know what to say, and so I looked down at Dr. Muirhead. He just sort of squinching in his seat. And I said, "That's very interesting, Dr. Moore. I really appreciate your comments that this is an interesting area, and I'm sorry we got different results." And that was the end, because my paper didn't mean anything, because he was the man. But later on, it turns out that the real answer was someplace in between. But on that particular day, the answer wasn't somewhere in between. The answer was in his ballpark.
I think that's an important story for young physiologists, graduate students, fellows, that when you go to meetings and things don't go as well as you'd hoped, it's not the end of the career, because one can go on and have a very distinguished career such as Dr. Mitchell's. I think that's important advice. While with Dr. Chapman, you did a very, very famous study on maximum oxygen consumption. Can you tell us a little bit about that study and how it got started?
After my 2 years in medicine, I decided to do a cardiology fellowship, and I think I was actually Carlton Chapman's first cardiology fellow here in Dallas. And back in those days, there wasn't a lot to learn about cardiology. You learned to read an EKG and to do a right heart cath, and you could learn both of those in just a matter of months. and I had 2 years. So those 2 years were spent doing human exercise physiology. And one of the things we looked into was the determinants of maximal oxygen uptake. I'd always been interested in how the body increased its oxygen consumption during exercise, and we knew that it was due to cardiac output, how much blood's going around, plus the AV oxygen difference, the delivery of oxygen. Nobody had ever quantitated how those changed from rest to maximal exercise. So we put in, took people and measured their oxygen consumption with a mask, put catheters in their brachial artery, brachial vein, and down their femoral vein, and drew samples while we progressively exercised them up to maximal. And we showed that the cardiac output goes up about 4-fold, both due to a doubling of stroke volume and a doubling of heart rate. And the AVD difference went from about 5 to 15, and those were the major determinants of maximal oxygen uptake. And then we looked at maximal oxygen uptake in patients with anemia, with patients with mitral stenosis, and did some further studies on human exercise.
If I remember correctly, these studies were published in the Journal of Clinical Investigation.
That's right.
And they were very, very highly regarded.
Well, thank you.
And cited quite a bit. Just as an interesting note, there was no IRB approval in those days, was there?
Well, we were doing quite a few, putting catheters in quite a few places, and you told the people what you were doing, but there was no IRB to see whether these things were okay or not. Much different than today. Much different than today.
So after you finished your cardiology fellowship with Dr. Chapman, you then went to the NIH to work with Stanley Sarnoff.
Yeah, that was very, very lucky, because while I was doing those studies with Chapman invited Sarnoff to come to Dallas to give a talk. And I met him, and he watched one of my experiments, and he said, what are you going to do when you finish this? And I said, well, I'm on the Berry plan. That meant Uncle Sam had deferred me to do my internship and residencies, but then I owed him 2 years before Uncle Sam, I owed Uncle Sam 2 years for letting me do that training. He said, why don't you come to the NIH and work with me? Because I was going to go to San Antonio and be just a doctor. And I said, well, that sounds great. So he said, well, I'll look into it. And so he arranged for me to change from the U.S. Army to the Public Health Service and come and work in his lab for 2 years, but I actually stayed there for 4.5 years.
Wow. And this was because of the draft. They were drafting physicians? Is that why you had?
Well, when you got deferred, then you had to pay them back, and I had gotten deferred during the war to do my training.
I see. And while in Dr. Sarnoff's lab, you also did some very famous studies about left ventricular function and the baroreceptors. Could you tell us a little bit about that?
Well, Dr. Sarnoff had become famous. There was Starling's law of the heart, which showed the relationship between the output of the heart and the filling pressure of the heart. And in Starling's time, there was thought to be one curve. And Dr. Sarnoff was the one who, in about 1951 or 52, introduced the concept of a family of curves that giving epinephrine to stimulate the heart could move the curve upward and to the left. Things that depress the heart could move it downward and to the right. And he had done all that work before I joined him. In fact, I read all that work, and that's one of the reasons I wanted to go work there. And when I got there, we were working on the role of the arterial baroreceptors, and particularly the carotid sinus baroreceptor. And we're showing that you could move these families of curves by lowering, when you lowered carotid sinus pressure, it moved the curve to the left or increased contractility. And when you raised carotid sinus pressure, you moved the curve to the right and actually decreased contractility. And we worked on that, and then also worked quite a bit on the atrium.
I must tell you that when I did my postdoctoral fellowship at UC San Francisco with John Coleridge, he told me that he thought that body of work that you had done with Sarnoff was the most significant advance in cardiology since Starling. Yes. So, I mean, those were really important studies, and I think you should be very proud of them.
Yeah.
You really should.
Well, in the atrium work got very interesting. That's the one that I presented to the American College of Cardiology. And when we started on that work, Dr. Sarnoff's, all of his work had been based on the fact that mean atrial pressure was the filling pressure of the ventricle. It was the same thing as left ventricular end diastolic pressure. But we were lucky to get one of the original Millar catheters where we could actually measure end diastolic pressure. And so that fellow named Dr. Andy Wallace and I started doing some studies comparing mean left atrial pressure to left ventricular end diastolic pressure, thinking they'd always be the same. But when we would stimulate the vagus nerve, we'd get them to move in opposite directions. And we stimulate the sympathetic nerves, we get them to move in opposite directions. So we said, what are we going to do with this data? This is in Sarnoff's lab, and all of his data, all of his studies are based on this fact that they're the same. So we said, we got to tell him. So we brought him in and not told him, but we sat him at the console in front of all the recordings and did these maneuvers, and he showed they went in different directions. And he said, well, wait a minute. And he recalibrated everything, and then we did it again. He said, now y'all come over here, I want to talk to you. He said, aren't we lucky that we found this in my laboratory, because all my work has been based on the fact that these were the same measurements. And we're going to publish a paper as quickly as we can on the differences and what causes the differences. And that's where the idea of the transport function of the atrium came along.
And for that work, you received the first Young Investigator Prize from the American College of Cardiology.
Yes.
Among many others, which I have on my list here, and we'll get to a little later. Okay. But that was quite a significant accomplishment. So then, after you left Sarnoff's lab, you then came back to Dallas.
Came back home.
Yes, came back home. Right.
And when I left here, it was sort of a tradition here in the Department of Medicine that Dr. Selden, well, there was not much school here, and so and Dallas wasn't a very popular town at that time. And so Selden saw he was going to have some trouble recruiting. He did bring a few good people in, but he thought he would just grow Texas boys into academics. And it's really amazing in my class of 100 students how many actually became academic. And that was all because of Dr. Selden. And his idea was to send you off, train you as a cardiologist or gastroenterologist or hematologist, and then bring you back to Dallas to join the Department of Medicine. So I was expected to come back in 2 years, but I was having such a good time in Washington working with Sarnoff that I actually stayed a little over 4 years. When I left Dallas, I left in a Corvette with a white Stetson hat, no cowboy boots, not a worry in the world, and went to Dallas. I went to Washington, D.C. or Bethesda. When I came back, I was in a station wagon with a wife, a baby in the back, and a dog. So my life had changed quite a bit during those 4 years at the NIH.
I'm so glad you mentioned that, because I really wasn't sure if I should bring it up.
Okay.
But that's quite a change.
Yes.
So you came back to Dallas, and Carlton Chapman was the chair of medicine at the time?
No, head of cardiology.
Was head of cardiology.
He was the
Right.
first head of cardiology in Dallas.
And could you tell us a little bit about the very famous Bedrest study that you did at that time?
Well, in 1962, when I came back, I, for the first couple of years, actually set up a human lab, animal lab, kind of like we had in Sarnoff's place, and wasn't doing too much human work when I first came back. Then Chapman was able to get some money and put 2 floors on top of the Danziger building here in Dallas, and that was going to be the cardiopulmonary laboratory. And one of the first studies we were going to do in that laboratory was a study that Dr. Chapman sort of wanted to do. And we wanted to, using maximal oxygen uptake as a phenotype, we wanted to see how much that could be changed by one's daily physical activity. And so we took bed rest as the lowest level of physical activity. And the bed rest that we used, we took 5 college students and put them to bed for 3 weeks, and they could move around in bed. They had to use a bedside commode. could sit up and brush their teeth. They were treated just like acute myocardial infarction was treated at that time. People were not allowed to get out of bed after they had a heart attack. They were kept very still for 3 weeks. We wanted to see what that alone would do if you didn't have a heart attack. And then we thought for the other side, we would do boot camp training for 8 weeks. And Dr. Gunnar Blomqvist was brought over from Dr. Gunnar Blomqvist and Dr. Beek Saltine were both brought over from Stockholm to help conduct that study. And then after the bed rest, they did 8 weeks of boot camp type training. And when they came in, we did a maximal oxygen uptake like I had done back in 58. Did it then, after bed rest, and after this training, and show that there's marked variation in maximal oxygen uptake according to what your daily physical activity is. Can be changed by 40 to 50%. Part of it's genetic, but the rest is how much you're actually doing. So this sort of changed putting people to bed for 3 weeks after a heart attack, or women used to stay in bed for many weeks after having a baby, and after surgery used to keep people in bed. But bed is not a good place to be, and so now people are moved around much quicker after any of these things happen. And then the bed rest start also led to head-down tilt studies, and Dr. Blomqvist became one of the world's leading experts on the effect of zero-G on the cardiovascular system.
So this study had several impacts, of which one was the advance in what we understand about space physiology, and also how people with infarcts are treated today. Is that a fair statement to say?
So, yeah.
Very, very, very important study. And I might add, that study has, over 1,300 public citations? I mean, it's been, And
we've repeated it twice more since. We brought them back 30 years afterwards, and then another 10 years after that, and we're thinking about bringing them back again. Problem is, one of the subjects has died, and all of the authors of that paper, except myself and Dr. Wildenthal, have died. Wow. Yeah. Dr. Carlton Chapman's dead, Beek Saltine's dead, Gunnar Blomqvist is dead, and Bob Johnson is dead. So time moves on.
It does. But then you shifted from studies on humans in terms of maximum oxygen consumption, bed rest studies, to animal work in neural control of the circulation. Could you tell us a little bit about that shift?
Well, I always got interested in how beautifully the cardiovascular response is matched to the intensity of exercise. If you get on a treadmill and start running, your heart rate doesn't go all the way up immediately. It goes up gradually, the stroke volume. Everything is very well adjusted. And when you do static exercise, such as weightlifting, the percent of how hard you're contracting your muscle determines the cardiovascular response. And I was just wondering, how does that happen? And so we did a study in 1966 here with Dr. Bill Willis, where we did a very simple thing. We just stimulated a nerve or muscle towards the heart and stimulated at different frequencies, and showed that when you hit the high threshold afferents, that you got a pressure response. The blood pressure went up and the heart rate went up just like it did during exercise. So I got sort of interested in the muscles and what role they played in regulating the cardiovascular system. So then I went to, in 1970-71, I was fortunate enough to spend a year in Oxford, and I went there to work with a Dr. Robert Torrance to learn how to record from the cardiac sympathetic efferents, and he taught me that. And then he took off to go work with Dr. Paintal in India, and I was just left with his lab and one of his people who just finished their PhDs there, who was McCloskey, Ian McCloskey. He was the junior faculty member there. He had been an MD in Australia, got a Rhodes Scholarship, and then got his PhD there in Oxford. And he had been a runner, so he was interested in exercise, and we started doing these studies in cats looking at what's coming from the muscle during exercise to regulate the cardiovascular system, and began stimulating the ventral roots to get a contraction. And we get a contraction, you get an increase in heart rate and blood pressure and ventilation. And if you cut the dorsal root, that response was going. And that had also been shown by somebody else in England just about a year ahead, John Coote. But we wondered which of the afferents are involved. And when I first went to Oxford, coming from the States, I was used to research conferences. Every week we'd go somewhere and somebody would give a talk, and you'd know what other people were doing, and then you could do collaborative studies with them. And in Oxford, there weren't any research conferences, so I just wondered how you knew what everybody else was doing. But then I found out that every morning at 10 o'clock there was coffee, and every afternoon at 3 or 4 o'clock there was tea. And everybody, including professors, lower professors, graduate students, doctoral students, all came to this, and you would sit with somebody different each time as you came in, and you'd figure out what other people were doing. So we were sitting in there one time, and I think Ian McCloskey and I were sitting on each side of John Whitcomb, who was a famous respiratory physiologist that had worked on the afferents from the lungs that cause the irritant afferent, what causes you to cough. And so he was talking about using blocks of the phrenic nerve to see which afferents were involved. And I'm sorry, the vagus nerve to see which were involved. And we talked to him. He said we all should be doing this to the dorsal root. So we got one of his technicians to teach us how to do antinodal and anesthetic blocks, and we were able to show that the fine muscle afferents, the group 3 or A delta and the group 4 C fibers, were the ones that were responsible for this.
I personally am very grateful you did that study, because it really laid the groundwork for what I was going to do in my career. But that paper that was published in the Journal of Physiology, I believe, is one of the top 10 or 20 cited papers in the history of the journal, which stems back to the 1890s at least, maybe even further. I mean, it's, once again, a very highly regarded, highly cited piece of work.
And well, those coffees and teas led me to do another study. Actually, we met a guy named Guy Goodwin who was doing his PhD with PBC Matthews there in Oxford. And we were talking about that there must be also a central command. In fact, a guy had done some of his work in Oxford who had called this cortical irradiation, that there was a central component to the regulation of the cardiovascular system during exercise. And we were sitting next to him. He said, well, have you ever thought about using vibration of the 1A afferents to activate the muscle? And we said, no. And he said, how do you do that? And he explained to us how we could either enhance or inhibit a muscle contraction by the 1A afferents. So we designed another series of experiments and showed that when you're making a contraction harder, even though you're doing the same thing, you're having to bring in more motor units. There's an increased enhanced cardiovascular response. And when you are, when you're helping with that 1A afferents, the cardiovascular response is not as great. And then when you are making somebody do it where you're inhibiting it, the cardiovascular response is greater to the same tension development. So those two studies really came from just meeting people at coffee and talking about the studies. Both the
paper in cats, where you showed what became known as the exercise pressor reflex, was very important.
Yeah, with your help, we did a review paper and named it, and we named it that together.
Right. And the paper with Guy Goodwin, which showed the experimental basis for central command, they have become the cornerstones of all the work done on neural-controlled circulation today in exercise. And once again, they've had tremendous impact.
Well, there's one other study that I did in Sarnoff's lab that we didn't talk about, and that is, I tried to give, after we had, Sarnoff had these meetings called TOFs. That means try on for size. And we'd invite people to come give talks, or we would give our talk ourselves. And Bob Torrance was in the lab visiting from Oxford for a year, and he had a friend named Fred Kao, who'd done a lot of work on regulation of the respiration and circulation by doing some very complicated two dogs hooked up together, or actually 3 dogs hooked up together sometime. He came down and gave a talk, and Sarnoff became sort of interested in exercise physiology. So we decided to do one study on the blood flow to exercising muscle. And when the sympathetic nervous system is turned on during exercise, why don't you get vasoconstriction in the exercising muscle? So we did a series of studies showing that during exercise, this vasoconstrictor response is abolished, or at least it's markedly attenuated. And we studied that and published a paper on functional sympatholysis, which also is another neural controlling mechanism during exercise.
Once again, a paper that has had a tremendous impact. A little later, you started going to Copenhagen, and you shifted from animal studies back to human studies. Could you tell us a little bit about that?
Well, I had wanted to do. We had changed the how hard something was trying, or make you try harder to do the same thing with these vibration studies. So another way to do that would be to do Kirari studies, and Kirari studies can be fairly dangerous because you can totally paralyze somebody with Kirari. But Dr. Bengt Saltine, after he left Dallas, went back to Sweden and then went down to Copenhagen to the August Krogh Institute, where he was working with an anesthesiologist named Niels Secker. And so Niels was doing a lot of Kirari studies. So I went and spent several summers working over there, where we would give people Kirari and weaken their performance, and then have them do the same amount of exercise, and show that when they were trying harder after Kirari, just to act like when they were trying harder after 1A effort vibration, that the cardiovascular response was greater. So that further solidified the concept of central command. And also, we were interested in these muscle afferents, so we began to do epidural blocks, which Dr. Secker was doing, and there was a guy who was doing a lot of epidural blocks there for OB patients when they're having babies. They're doing epidural block, and it was able in Copenhagen to get permission to do epidural blocks on normal volunteers. And Niels began to do these, and we would paralyze the afferents, but also when you paralyze the afferents with Novocaine, you also get the motor fiber. So we had to do work at the same relative intensity and the same absolute intensity. And again, showed in those studies that there was both a central mechanism and a peripheral mechanism regulating the cardiovascular system during exercise.
Was it difficult to recruit subjects for this? For instance, were the patients given Kirari, were they ventilated?
Dr. Secker, besides being an anesthesiologist, won the World Cup in the single skull and then also in the double skull. So he's sort of a hero in Copenhagen, and was still going to the rowing club, and all the young rowers thought he was God, and so he would recruit them. So we had really well-trained, ideal subjects who would take the Kirari or the epidural blocks.
Fascinating.
Yes.
And did you ever serve as a subject in these studies?
Not over there. I didn't. I served subjects in Dallas in one of my maximal oxygen uptake studies.
You're a braver man than me. I think I'd be very frightened to do these studies. It's truly remarkable. I'd like to shift a little bit talk about grants and the NIH, and talk a little bit about program project grants. I have right here the very first program project grant that your group had generated, and I'm going to hold it this way so you can see how thin it is, because compared to a program project grant today, it's, I think this will drive anybody writing a program project grant today, they'll drive them nuts, because this is truly amazing.
And that's for 7 years.
This was for 7 years, and the grand total was $48,747. And I think I counted, there's 4 pages of text with rather large print and budgets and CVs and everything. So the world's really changed. And this was the original application was by Dr. Chapman. And then you took it over in 1966. Mm-hmm. And then you had it for
36 years.
Yeah. So that's 7 renewals, a little more. I mean, that's quite an accomplishment.
And then after that, Dr. Sandy Williams got it renewed one time, and then Dr. Jim Stull. So it's I think the total years there is something like 40-something, and that's one of the longest program projects of the NIH.
Amazing.
I think Frank Abood has one that's still going, so he's past us. My best story on funding was at the NIH, because once a year in the spring, Sarnoff would come around on us and say, "We got to put in a budget tomorrow. What do we need?" And we would just make up a lot of stuff and say how much money would want, and he would kind of double that and go to Berliner, and we'd get the money. And so we'd spend one half afternoon a year working on getting a grant, and that's very different from what you do today. And even here, you'd work on a grant every 5 years.
Yeah.
And then the rest of the time you would do the research.
Yeah.
And now you work more time getting money than you do doing the research.
Yeah. Did they have site visits in those days?
Oh, yes. I loved site visits because it was almost like going to the Olympics every 5 years instead of every 4 years. And they'd bring a wonderful group down. We would practice, and they would come and spend 2 days and see the lab and see what we were doing, talk to us. It was an expensive way to do things, but it really was a wonderful way to evaluate a group and what they're doing. And I don't think reverse site visits or no site visit is near as you don't get near the information that you did back in those days.
I'd like to shift a little bit and talk about mentorship. You've had 33 postdoctoral fellows work for you over the years, 7 predoctoral fellows, and many have gone on to very distinguished careers. And I'd like to know not so much what the secret of your success is, but a little bit about what your philosophy. Why did so many people flock to work with you, and how you trained them?
Well, one thing is I never advertised to get fellows. They always came to me and wanted to work, and I think that's kind of nice. And then when they knew what I was doing, and when they would come to the lab, I would suggest a few projects, and then they would get started on one, and they would be on their own, and we would have meetings to see how the data was going. And I frequently like to have more than one working on a project. We'd maybe have 2 guys doing 2 projects, so both of them could be a senior author, and then they would get going on that. My main problem was I would have, when they'd give some ideas, and I'd have some more ideas, and sometimes I'd make the mistake of giving my next ideas, and some postdoc fellows were smart enough to ignore those and keep on working on what they were doing. But then some, every time I'd come in with a new idea, would change what they were doing, and I was a very bad mentor for those kind of people who didn't set a goal and go ahead and follow it all the way. But I really loved working with fellows.
I think possibly the reason people would shift from one idea to the other is that they were always really exciting ideas, and I was the beneficiary of that. And you had to finish one, but you always had great ideas, and they were really interesting, and you were so easy to work with. I mean, I remember how your door was always open, and you could be on the phone with some very important people, and we could just walk in your office and sit down and start chatting with you when you were finished with the call. And you weren't bureaucratic, you weren't aristocratic, you were very open and friendly, and so easy to work with. And you were a real role model.
We had some great years together.
We did. But several people, we could name that have done very well. Tony Waldrop is now president of a university.
I seem to train more administrators than I did scientists, because Curran Wildenthal became president of UT Southwestern Medical Center, and Charlie Mullins became the provost of the University of Texas in charge of all health affairs, Tony Waldrop. Now Scott Smith is my lead is new dean. John Williamson is the dean of the Health Science Center. Is dean of the Health Profession School here, and Scott's working over there now. So
you should be very proud. It's done very well.
I don't know how in the world anybody learned anything about administration from me, because I am the world's worst administrator.
Well, you can't argue with success, Jerry. You've really done spectacularly well. Could you tell us a little bit about what the American Physiological Society has meant to your career?
Well, in 1958, when I was working with Carlton Chapman, I went to Philadelphia to the American Physiological Society meeting and gave my paper on maximal oxygen uptake. And lucky to say it was very well received. Dr. P.O. Ostrand from Stockholm came up and talked to me, and also Dr. Sid Robinson came up and said, you know, I have a hard time getting that kind of data in dogs, and I'm very glad to see you getting all these catheters and doing this stuff in people. So that was the first meeting, and also I had a chance to talk to Sarnoff there, because that was in April, and I was going to be joining him in July, so we had a chance to work together. And when I was with Sarnoff, we went to all the meetings in Atlantic City to present our work, and because he always was pleased to have 4 or 5 or 6 papers on the program. And all of that was in the cardiovascular part, because it was all ventricular function, atrial function, that type thing. And that's where, when I came back to Dallas, all my work was with the circulation group. And I one time gave the Wiggers got the Wiggers Award, was able to give the Wiggers lecture. But then after that, my research interest became more the neural control of the circulation during exercise. So my next I got interested more in the environmental and exercise physiology section, and switched my primary allegiance from circulation to that section. And then when NCAR came along and was neural autonomic control and regulation, my work was really neural automatic control during exercise. So it really sort of spanned 3 different sections: the circulation section, the EEP section, and the NCAR section.
I think I would be remiss in ending this interview if I didn't list some of the many awards that you've received. I apologize for embarrassing you, but I really do think that this is important. You've had a very distinguished career, and I just made a list of the various awards that you've won, some of which we've mentioned, but Dr. Mitchell received the Young Investigator Award from the American College of Cardiology, and that was the first award they had ever given out. And then subsequently, he got the Distinguished Scientist Award from the American College of Cardiology, and he's the only one to have received both awards. As he mentioned, he received the Wiggers Award, which is the most prestigious award from the cardiovascular section of the American Physiological Society. From the Environmental and Exercise Physiology section, he received the Adolph Lecture and the Honor Award. From the Neural Control and Autonomic Regulation section of the American Physiological Society, Dr. Mitchell received the Carl Ludwig Lecture. And from the American College of Sports Medicine, he received the Honor Award and gave the Wolf Lecture. From the Physiology Society, which is the one across the pond, he received the Peyton Prize Lecture and has been made an honorary member of the Physiological Society. There's more, but I think I'll stop there. But there's many, many awards he's received, and he's had quite a distinguished career. This concludes our interview. Thank you for being interviewed, Dr. Mitchell. Thank you for watching.